Alrighty, we will go ahead and get started. Good evening, everyone, and welcome to the Indiana University Correctional Outreach Project's first speaker series. We are thrilled that you all could be here this evening as we continue to increase our knowledge about medicine, gender, and the carceral state. We've had the privilege of partnering with the amazing women who created the Indiana Women's History Project. Tonight, you will get the chance to learn from them, their experiences, and the work that they have done within the Indiana Women's Prison. Through this series, we have taken a deep dive into the complexities that exist as we merge medicine and the carceral state, specifically for women within IWP. Over the course of this series, you have heard many stories, you have started to understand the why, and most importantly, we hope you have left feeling empowered to make a change. We will continue to endeavor in that as we step into our last session this evening. Without further ado, I would like to provide you all with a brief background of the History Project and introduce our wonderful speakers for tonight's Time, Trauma, and Healing session. The Indiana Women's Prison History Project is a group of formerly and currently incarcerated students who do original research on the history of gender and the carceral state. The IWPHP scholars have presented their research at national conferences like the American Historical Association and the Organization of American Historians, as well as local conferences like Hoosier Women at Work, and the IWPH is publishing a book within the New Press in 2022, edited by Michelle Daniel Jones and Elizabeth Nelson, on the history of the women's prison in Indiana. I'll first start introducing our first speaker, Dr. Elizabeth Nelson. Elizabeth Nelson is an assistant professor in the Medical Humanities and Health Studies program at IUPUI. A medical historian, her research focuses on modern institutions of confinement, such as mental hospitals and prisons, on examination of structural racism, sexism, ableism, and the production of poor health, disability, and premature death is a necessary part of her work. However, Dr. Nelson is especially interested in creativity, knowledge production, community building, and activism in these institutional spaces. Humans striving within and against oppressive and inhospitable environments. Central to her work are questions of rehabilitation, care, structural violence, haunting, trauma, reform, and theories of time and history. Currently, Dr. Nelson is co-editing a book with Michelle Daniel Jones by members of the Indiana Women's Prison History Project on the history of women's incarceration in Indiana. She is also co-authoring another book that examines the expansion of rights for people with intellectual disabilities within doomed institutions, Indiana's Central State Psychiatric Hospital, on the eve of its closure in 1994. Next, I will introduce our next speaker, Anastazia Schmid. Anastazia is an artist, activist, and PhD student in the ethics studies at University of California, Riverside. She blends her knowledge and artistic expression in her work and contributes her time and talents to numerous charitable, activist, and outreach causes. She is a founding member for the Indiana Women's Prison History Project, a research team engaged in rewriting the history of women's prisons and institutions. Her area of emphasis is 19th century gender and sexuality, the history of gynecological and obstetrics, medicalization of women's bodies, sex work, injustice, violence, and trauma. She also works in collaboration with the Abolition Journal Collective, IDOC Watch Anarchist Collective, the Lumina Foundation, National Council of Incarcerated and Formerly Incarcerated Women and Girls, Constructing Our Futures, Focus Reentry Initiative, Silent Cry Inc., Underground Scholars, and Memento Mori Paranormal History Hunters. We have two very amazing speakers for you all this evening. So without further ado, I will pass it over to Dr. Nelson and Anastazia Schmid.
Excellent. Thank you for that introduction and for the invitation to present the third part of this series. I'm going to share some slides here. Here we go. So unlike the two previous installments, which really had two speakers, each kind of, going back and forth with a formal presentation, this is going to be much more conversational, and it's really going to focus on Anastasia's research and expertise. And I will basically be interviewing her in a way, but it'll be a conversation as well. So I don't have a whole ton of slides, but I do have a few that I'll kind of throw up periodically. So I'll be going from the screen share to not as we go along, just to add some visual interest as we talk. I do want to kind of highlight just to give you all a framework before we start of what we'd like you all to take from this presentation. We'll be discussing Anastasia's research on 19th century medicine in the Indiana Women's Prison, and she'll discuss how gendered, sexual, and medical violence is at the very foundation of the prison system, and how that relates to how we should understand prisons today and the experience of incarceration today. We'll be talking about histories of violence, both individual or personal histories, as well as history in the larger sense, so the kind of societal history of prisons and their violent origins. And the kind of thesis I guess we want to present today is that these histories matter, they mark the present, they continue to reverberate and shape the present. And so we'll get into discussions of trauma, for example. Medical practices in prisons are often disabling and they perpetuate trauma. And this next point goes back to what we've been hammering on throughout this series, the role of the health professional. As health professionals, you all have a unique responsibility and power to stop these abuses. But alongside that point, we also want to point out that healing is a much bigger process when looked at holistically than just medicine. And so when you're thinking about healing and you're working with folks, medicine is just one tool for healing, but you should also take into account other things that people need: community, spirituality, creative expression. We'll be talking specifically today about the arts and their role in healing. So I'll stop this and I'll begin with my first question for Anna. So among all of the researchers who are associated with the Indiana Women's Prison History Project, Anastasia's research is perhaps the most directly focused on the history of medicine. So we'll talk a little bit about that, and then we'll move into some of the connections between that history and the current day. So during the first part of this series, I briefly mentioned the history of medical experimentation in prisons. And Anna, I noted just briefly in that first presentation that your research found evidence of medical experimentation at the Indiana Women's Prison that was happening just from right when it first opened in the early 1870s. So could you tell me a bit about how you came to your topic of research, what you found was going on at the prison, and how your research perhaps counters what people previously thought about medicine at the early Indiana Women's Prison?
Thank you. Okay, there is so much to all of this. I'm going to do my best to be as brief and concise as I possibly can. I came into my area of the research with the project because my undergraduate degree was in psychology. So I was very much interested in looking at mental health and mental illness and psychiatric issues and how that side of medicine was factoring into the prison. Although I really was not a historian at that point in my life, I did have quite a bit of historical background on asylums and lots of things that were going on psychiatrically, particularly with women, early 20th century, 19th century, and so forth. So I was interested in wanting to know how and why and who was deciding which classifications of women went into which institutions. Like, what was the delineating marker that would send one woman to prison and another woman to an asylum, for instance? So this was the initial questions I had going into the research. We pretty early on came across Dr. Theophilus Parvin, who was the prison's first physician and remained employed there for the first 10 years. And on the surface, Dr. Parvin looks like this amazing guy. He was president of the AMA partway through his tenure at the prison. You know, what we found in the prison records, specifically in his notes, it seemed like he was doing good work there. He was treating the women for malaria. He was an advocate for fresh water and exercise and being outdoors in the air, and, you know, just a plethora of these good things that he seemed to be advocating for and doing for the women. However, because of my direct personal experience with the carceral system, and specifically through mental health and medicine in the prison, I was instantly wary of this man. You know, when some of the rest of the cohort were like, wow, isn't it amazing that the president of the AMA was working at the women's prison? I was like, no, this is not amazing. I mean, we have the most substandard healthcare and psychiatric care anywhere. So why would the president of the AMA be deciding to go work in a women's prison? It was an immediate red flag for me. So we started digging. It took a lot of help from outside researchers and state archivists, because I was not finding the answers I was looking for in the prison records. But my gut was telling me what I knew from my own direct experience and what I knew from the experience of other women around me, that there was more to why this man was choosing to work inside a women's prison. So through pretty extensive research into his background, into his publications in medical journals, talks that he had given at other universities. Some of his publications were printed in other states, and then eventually some newspaper articles. More of the truth started surfacing about Dr. Parvin and what he was actually doing inside the prison. His most noted work, The Science and Art of Obstetrics, is the medical textbook that he produced and published about 3 years after he left the prison. And my long-standing argument was that in order for him to achieve the work that he did to the level he had done it, he would have had to have pretty much an endless surplus of women to be using to gain this knowledge from. And it turned out that that knowledge did indeed come off of the bodies of the women inside the prison. He was an advocate of ovarectomy and clitorectomy. We do know he talked extensively about abortions, about different types of surgical procedures for things. And the interesting thing was, nowhere in his notes in the prison record does he ever identify performing surgery on anyone. And yet when we go to his other publications and we start reading through the journals and the textbooks and all of these other publications he put out, there would be specific entries where he would list what he was doing to women inside the prison. Now, most of those women remain nameless. Often they would only be identified by an initial or perhaps their age. Once in a while, race was mentioned, and I think that's pretty important too, because I realized the only time he actually mentioned a woman's name was when the patient happened to be an African-American woman. He never mentions a white patient by name unless she had died for some reason. And even then, there were such discrepancies within the records. Like, there were times you would see the numeric listing of how many people had died, but they wouldn't actually list a name of who it was. But then when you'd go to these other publications that he had written about work he was doing and experiments he was conducting inside, then you would be able to place a name or at least some type of identifying marker with who had actually died in the prison.
Could you talk a little bit about how his work, like the virtuous vagina, for example, and how it related to the kind of management of sexuality, gender roles, et cetera?
Yes. Okay. So this is where he and the superintendent, Sarah Smith, kind of join forces, I guess you could say. She was a Quaker reformer, and everything was based on this religious ideological model of the ideal female. Dr. Parvin shared her views on what the ideal female was. So pretty much any woman who had any type of desire for sex or sexual intercourse, women who were masturbating, in his words, you know, in that time they were calling it self-abuse, were subjected to treatments. Those treatments included what's kind of the equivalent of what we would know as waterboarding, ducking, cold shower baths, all of these types of things that he was doing to these women for these things. It's the equivalent of like repeated simulation of drowning. Like water, either the head would be forced under the water or rushing water would be forced upon the face and the head repeatedly till a point of almost near drowning, stop for just a moment, repeat it again. Some of the reports we found through the investigation of the abuses at the prison, some women were subjected to this 30, 40 minutes at a time, maybe more. One woman in particular, he claims in his records that he was treating in this way for urinary incontinence. So, I mean, it wasn't just sexual proclivities. It was other things that he was deciding these were appropriate treatments for these women. But some of the girls too, particularly when it came to masturbation, there were girls as young as 12 and 13 years old that were essentially being water tortured for this, or locked in solitary confinement, sometimes both, kept naked, hosed, fed a limited diet of bread and water. I mean, just extremely severe and harsh punishments.
So, I mean, when I think about Parvin, I think about, and your research has made this connection, thinking about someone like J. Marion Sims, who made his career off of the bodies of enslaved women. You can kind of see Parvin as part of that lineage, also, you know, also president of the AMA. And when you start thinking about the stature of these 19th century doctors and the source of their knowledge and the human subjects that whose bodies they essentially harvested this knowledge from, it starts to paint a picture, right? What I want to move to next, just for the sake of time, is, you know, because I think there's a lot more we could say about Parvin, but for those who are thinking, okay, well, that was the 19th century. We don't do that kind of thing anymore. Could you talk a little bit about why your findings about Parvin and your research generally has resonated with you, and what aspects of it, you know, connect to experiences that you've had or witnessed while you were inside?
Sure. I think there's two main things that really stand out to me in this. As far as Parvin continuing the legacy of Marion Sims, throughout the course of my research, I did indeed find modern day forced sterilizations continuing to happen in women's prisons. Right now, I'm part of a group in California that are fighting against the forced sterilizations that have happened here, some of them as recent as 2015. We've uncovered more that have happened since that time in the ICE detention facilities and other places. There's an excellent documentary put out on this called Belly of the Beast that highlights the story of a woman named Kelly Dillon. And she was sterilized without her consent while serving time in the California Women's Correctional Facility. So this is something that has continued to go on, whether they're documenting it or not. It's been happening. And this is part of the foundation Parvin laid down, was by using these women as experimental subjects inside, particularly when it came to gynecology and obstetrics. The practice has never quit. It's continued across time. And we're still uncovering this happening to women to this day. I knew a woman personally when I was inside. She did not have a psychiatric disorder, diagnoses, nor was she on medication prior to prison. She comes into prison, They give her a diagnosis that was inaccurate. They put her on a bunch of psychiatric medication, namely Thorazine, among others. And one day they send her to see the physician, and they tell her that they're going to have to give her a hysterectomy, that she had an abnormal pap smear. Now, the interesting thing about this is this particular woman actually had a hysterectomy before she ever came to prison. So and she's but one story that I heard over time of these women that they would try to say, oh, you have to go see the gynecologist. And the next thing you know, they're telling them they had abnormal paps and they were going to have to remove something or cauterize something or whatever. But this one particular woman, it just blatantly speaks to the fact of that there's something else going on. There's some other kind of an agenda. The woman had already had a hysterectomy. So that's one side of it. The other side was me realizing how extremely hyper-criminalized women's sexuality remained in prison, even in the 21st century. Particularly homosexual women and gender non-conforming women. This was the most criminalized, the most hyper-policed activity inside the prison. I mean, most people would think, just common sense would tell you, oh, well, maybe they would be concerned about violence. Absolutely not. They were concerned about women holding hands, women kissing, women engaging in any kind of physical activity. As a matter of fact, it is more harshly punished if you are caught touching another person in any way than if you would actually physically assault them. So I'm one person that experienced this directly. I had been put in solitary confinement once for 75 days because another woman touched a bracelet on my wrist. Another time I lost 120 days of good time because someone kissed me on my cheek. So these are the types of things that are continuing to happen. And what this essentially means is, one, women are put into solitary confinement for this. When you go into solitary confinement, you lose all other rights and privileges inside the prison. So you will lose your visitation with your family and your children. You will lose any programming you're in, which in Indiana, a lot of the programming earns you good time credit, which means an early release. So that's going to hold you in prison even longer. Or like was the case with one of the situations with me, they actually took good time for me. So due to a kiss on the cheek, I was supposed to spend an additional 4 months in prison for that. And so when I was having this kind of experience over the years with myself and watching other women, I could not wrap my mind around why is this so hyper-criminalized and so hyper-policed. And it wasn't really until I got into the historical research and I started realizing that the entire institution was found essentially on preventing women from having sex. Then it starts to make more sense and the picture becomes more clear. So those two things specifically.
So yeah, I want to dig a little bit deeper into some of the things that you've said about psychiatry. We've touched on solitary confinement in some of the previous presentations, the use of psychiatric medications as a form of chemical restraint as opposed to a true therapy. And so you might talk a little bit more about that, but I'm also curious too, if you could go into more detail about the power of diagnosis, either misdiagnosis or once a label of, okay, you have this psychiatric condition, once that label is placed upon you, what the implications of that can be.
In the most general sense, it's one of the ultimate weapons of silencing. Once a person has the mental illness label, whatever that looks like, the person is then crazy. Crazy people are not to be believed. They're not to be listened to. It's this false assumption that anything the person is saying is some type of delusion or fabrication of the mind rather than reality. So once somebody has this kind of a label, particularly in an environment that is already so steeped in violence and harm, when that person attempts to speak out against what's happening to them, they're automatically not believed, dismissed, It doesn't go any further. It's always extremely easy then for people in positions of power to say, oh, no, 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 you know, this is just part of their illness. It's part of the stories they're making up, but it's not reality. And so people aren't listened to, they're not believed. If and when they do speak out against these things, that then becomes grounds to increase medication, continue solitary confinement, or some other form of restraint or silencing mechanism. When medication becomes involved with people, and this is particularly important in a carceral setting where people are trying to fight legal rights. Once medication is involved, a person is not fully cognizant nor competent to defend themselves or to aid in that process. So this form of chemical restraint is also used to silence people so that, one, human rights violations can continue to happen, and two, legal violations can continue to happen. Because if you have become mentally incapacitated due to drugs, you're incapable of fighting your own defense. You're incapable of moving forward. And this is a huge problem. I mean, particularly if this is happening to people in preliminary states of incarceration, like was the case with me. They medicated me beyond any type of normal mental functioning preceding my trial. So I was left in a state that I was absolutely incapable of defending myself. And at that point in time, a legal defense is made for a person, but not by a person, which is a constitutional rights violation, which is indeed eventually how I won my federal habeas corpus and was released from prison. It's a complete violation. So what happens is you're rendering people incapable of really even basic normal functioning, let alone something as pertinent as fighting a legal defense for their life.
So you're talking about silencing, and I know a lot of your work, your research, as well as your artistic projects and so forth have been focused around amplifying voices that have been overlooked. You last year were in the medical humanities program with me, doing a graduate certificate, and so last spring you did a project that involved interviewing several currently and formerly incarcerated women about particularly their medical experiences. And I was wondering if you might share a little bit about that project and maybe key, I don't know, stories or takeaways that you took from that.
So I think some of that work is preceded by work I was doing while I was still inside. You know, there's plenty of statistics available out there as to the number of women incarcerated that have trauma in their backgrounds. I'm going to argue right now that whatever number you see as reflected, and it is going to be an extremely high percentage anyway, that number is actually higher than that. So I became a mentor and a peer facilitator while I was inside. I was teaching several different programs and classes. And what I was finding was this common thread between basically every single woman I had encountered, that there had been sexual violence, physical violence, domestic violence, psychological violence, childhood sexual trauma and sexual violence, neglect. I mean, the list went on, that pretty much every woman there had experienced this in their background prior to coming to prison. So this becomes extremely pertinent because what we have is a population of women who already are suffering from trauma disorders, sometimes very extreme trauma disorders. Now they have been put into an environment that is inherently violent and inherently will create harm on multiple levels, what I have now realized, particularly psychological levels. So even if someone is not being physically attacked or sexually attacked, it is the low-grade psychological abuse that is happening day in and day out inside the carceral setting that starts to take a toll. So coming to the other side of the fence, and I just want to say this, in theory, I am one of those people that would have been considered the poster child for rehabilitation. I had done absolutely everything that was allotted to me while I was there. I had created new programs. I'd worked very hard. I built a large network of support and people. So in theory, coming out the other side, I mean, I should have been golden. Life should have been great. No problem stepping into a successful reentry. And what I found in reality was something very different. And it took me several months to gain enough courage to even begin speaking about this, because I thought, if I'm this person who has done all this work to not only correct the pre-existing problems in my life, but work diligently to be able to start a successful life on the other side, and I am having all these bizarre psychological problems now that I could not articulate at the time. I have complex PTSD. That diagnosis was there prior to prison. But what I was experiencing on the other side was something distinctly different. It was similar in some ways to what I experienced with PTSD, but it was also something new and something different. And it was, like I said, it was so difficult for me to learn how to articulate what I was experiencing. And it was not until I began speaking with other women, particularly other women who had served long sentences like I had, that I start finding these commonalities. And so I finally found a woman named Shawana Vaughn through the National Council of Formerly Incarcerated Women and Girls. And Shawana has named this problem post-traumatic prison disorder. And so what we are now arguing, we're researching on, and we're doing activism on, is that this is a new, nuanced, very specific trauma disorder that affects people who have been incarcerated, particularly people who were incarcerated long-term, or people who have matriculated in and out of the system multiple times. And it stems from so many different things that are happening in the carceral setting. Like, I think one of the easiest, most baseline ways I can describe this is that incarceration is a chronic state of grief and loss. It is every single day that you are there, you are losing something and grieving over something, whether that be some portion of your life or your people in the outside world or something inside. For any reason or absolutely no reason at all, you can lose anything just like that. No explanation. So people stay in this constant mentally worked up state of anxiety, because it's a constant feeling of, for lack of a better term, waiting for the other shoe to drop. It's like you stay in a chronic state of hypervigilance because something is always happening, something is always being taken from you. And it's the arbitrariness of it. Sure, there's a rule book, there are certain things, okay, you cannot do this, you cannot do that. But officers have the ability to kind of just make up a rule one day for whatever reason. So to give you an example, like maybe one week somebody in a position of power decides that they want to focus on the way people are tying their shoes that week. And so for days on end, all of a sudden, all the officers are hyper policing the way people's shoelaces are tied. And if your shoelaces are not tied the way they want them to be tied, there's going to be punitive measures and sanctions. So it's these kind of things. So then maybe the following week, maybe it's the way your shirt is buttoned or the way you're wearing your pants that day. I mean, it's these tiny little nuanced things that are absolutely no big deal that suddenly become hyper policed and punitively sanctioned and are completely arbitrary. So it's these little types of things that are happening day in and day out and day in and day out that is really starting to create these emotional psychological scars. And sometimes, like I said, like you're unaware of how bad you're being traumatized until you're released. And, I kind of touched on this earlier. Touch in any capacity is illegal inside prison. So any type of just normal human touch and interaction, it is completely illegal. It is punished more severely than acts of violence. And so what happens, as human beings, we were designed to have human connection, human touch, and interaction. But when you are being hyper policed and hyper criminalized for normal human activity, something happens that's not okay, and I still don't even have the right language to fully articulate this, but you're essentially starved from normal human behavior and activity. So when this is going on for year after year or multiple decades, you're not right coming out the other side. I mean, it's almost like you no longer know how to properly function. You're constantly putting yourself in a state of check of, can I do this? Can I not do this? It's sort of the state of learned helplessness almost. You feel like you're damned if you do and you're damned if you don't. People having extreme fear of authority figures, surveillance, any kind of thing like that. And I heard this repeatedly from women, like the mere sight of police officers would send people into panic attacks. Normal activity, like walking into a Walmart and seeing the surveillance videos, people would almost become immobilized with fear. The other thing, for those of us who served a long time, we came out to a world we didn't know anything about. Technology is a huge thing, and technology is now a part of everyday life. You cannot function in the normal everyday world without having some semblance of basic knowledge of working technology. But when a person has been completely left away from that, given no type of education, no type of training, no type of exposure to this, you walk out the door of the prison and they say, okay, get a job, get your place to live, go lead a good life, do everything you're supposed to do. And you're completely incapable of navigating through everyday life in the world. It creates psychological meltdowns. People just become immobilized. They freeze up, they freak out. You're infantilized when you're inside. I mean, all major decisions are made for you. So you come out to a world you no longer know anything about. You have already been put in a perpetual state of dependency. Now you're dependent for real because you cannot function in the outside world. So what I found through talking to all of these women now for almost the last 2 years, I'm finding that what we're calling post-traumatic prison disorder is the foundation to recidivism, to relapse, to alcoholism, to suicide and suicide attempts, to breakdowns in interpersonal relationships, to failings in school, to inability to either gain a job or hold a job. I mean, pretty much anything you can see on the list of problems and or why a person would return to prison, this is the core. This is what's underlying all of it. And it's not being addressed.
Yeah, and I wanted to jump in and we were talking about this the other day on these things when people do run into problems, relapse or whatever, it's chalked up as an individual failing, right? And not seen as a product of the system. And when you think of the scale of the system, the millions of people that are moving in and out of carceral spaces, think about the just like the level of public health impact, if you want to put it that way. But just in general, the lack of systemic thinking about these kinds of problems and the way that people internalize failure as if it is, you know what I mean, as if it's their sole, failing, as opposed to a product of this kind of vast machine that is producing this kind of disablement, producing mental health, producing, trauma, producing mental health issues, et cetera. So I just wanted to jump in there and say that. I do want to talk about healing for our last, say, 10 minutes or so. And this goes back to the point about the process of healing being bigger than just medical interventions. And so I wanted to ask you, First about the Sacred Writing Circle, and then we can show some of your artwork in the last few minutes. So you ran a writing circle on the inside. Can you tell what the kind of origin of that was, what it looked like, and what role that played in promoting a healing environment, even inside of this carceral space?
Yeah. So like I said, I had pretty much taken any and every program, educational, vocational, therapeutic, whatever opportunity the prison was offering. I found that the majority of those things were grossly deficient, not just for myself, but for other people. Being a lifelong artist and writer, I started to kind of do my own things that I knew I needed to do to be okay. And writing was one of them. So, it was not uncommon for me to be sort of off by myself somewhere, sitting with my notebook, just writing away. And, this was several years back. A couple women came up to me one day and they're like, what are you always writing in that book? And I'm like, well, I'm just writing. And they're like, they just started asking me questions, which led me to read them some of what I wrote. And they're like, wow, that's like amazing. Like, could you teach us to write this way? And I'm like, well, I hadn't really thought about it, but sure. So a group of women ended up coming to sit at the table with me. They all got their notebooks. And I started to say that I had found when I would write with absolutely no rules and no censorship, just raw, straightforward writing, like stream of consciousness almost, just a purge of whatever thought I was having without any real direction or structure. This is where I was finding revelations, not only about my own life internally, but in larger things, and was sometimes creating some extremely beautiful poetic prose. And so I started, without really planning it, this group materialized, and that was our sacred place, hence the name, the Sacred Writing Circle. We would set apart so many hours, usually on the weekend, and that became very symbolic too. So many of the women I was incarcerated with had problems with addiction and had talked to me extensively on things that had happened in their life prior with their addiction. And the weekend in particular was such a trigger for people, particularly people with addiction problems. So we decided that Saturday night would be the time for the Sacred Writing Circle. Roughly 8:00 at night, the same time frame that women would once have engaged in activity that was going to lead to any number of other problems. We set that time aside for ourselves and for each other, and we would write. So I would give people a prompt just as a place to start, but my rule was there were no rules. You're just going to write. The only rule is the pen moves across paper, does not matter what comes out. There's no judgment here. There's no critics here. We're just going to write. And when we get done, we're going to share what we write. We're going to honor and respect each other, the time and the space to just actively listen. And what we started listening for was what was not being said. We started to learn to actively read between the lines of each other's writings, to help each other uncover what was lying beneath our thoughts, our experiences, our feelings. And some miraculous things happened. And, the reason the circle was so impactful and so healing and worked so well is because I was directly impacted too. I was another one of these women. I was not somebody employed by the state. I was not somebody through one of these things that I'm going to turn around and use whatever you say against you, which is absolutely what happens in every other capacity inside the prison. Women would go into therapeutic groups in the prison and still never become fully honest because they knew certain things you say, you will be retaliated against, and probably punitively in some way that is going to cause harm and or violence. And so people wouldn't talk. You can't get help if you don't feel safe and that you cannot speak the truth. So the Sacred Writing Circle was our place to speak our absolute truth, whatever that looked like, however we needed to say it amongst each other. And what we started finding was the common ground that all of us had. And through that, we find this level of support and solidarity that was non-existent everywhere else inside the prison. And this is why it was effective for myself and for the other women that I continued to work with through this process for years. Sometimes I would put other artistic elements and pieces into the writing. Some of the artwork that Elizabeth will show you tonight is based off of some of those original models of prompts that I had created with the writing circle.
So yeah, I'll go ahead and introduce, we have 2 slides. It's a 2-part series of paintings that Anna recently created, Distortions of Humanity, Challenging the Face of Carcerality. This is part 1. I'll let you explain.
Okay, so the idea of these abstract portraits, like I said, came out of the writing circle. What I also found was commonality with the women inside was very, very low self-image. Sometimes that was due to trauma or domestic violence, and or just the stigma of carcerality itself, the stigma of being labeled as a felon or mentally ill or whatever the case may be. These labels that have been put upon these women that made them think and believe and feel and be treated as though they were less than human. So women had such a distorted image of themselves based on all this external things that had happened to them, particularly trauma, and particularly what the carceral state and the felony conviction had done to them. So this style of drawing is known as blind contour. And essentially what you do in a blind contour is, if you are my subject, I am going to look at you and not my paper. I'm going to put my pen on the page. And while looking at you, not the paper, I am going to draw in one fluid line what I'm seeing. And what you come up with then is this kind of distorted image of the person. So what we would do in the circle is we would do this with each other. We'd pair off in the circle. You'd have a partner. You do the blind contour of them. They do the blind contour of you. But then to try to change that distorted image, we would pass each of these blind contours around the entire circle. And every woman in the circle would put a word on top of that portrait of how they saw that woman, who they saw them as a genuine human being, not the labels, not the negative things, the beautiful things, the beautiful qualities and aspects they could see in these women. And we would start to build these collective art projects. So this current project was sort of birthed out of that idea. And now I'm working to take this a step further. This particular series was done on women who were labeled as quote unquote violent offenders, who served long sentences, some of which had very sensationalized cases, and that taint of criminality harmed them not only inside, but continued to harm them in some way on the outside. And so this is the challenge to those notions of them being less than human, being violent, being monstrous, being these kinds of things.
You want to go on to the next one?
Yeah, you can. Yeah, so this is a further extension of the first part of the series. And yeah, I mean, like, even though I'm the creator of all of these, they were all a collaborative effort. I conducted interviews / just conversational dialogues with these women. The colors you see represented, those are the colors they have chosen for themselves. The words that are inside each of the portraits, those are their words. And in each of them, you will also find, if you look, a mantra, a phrase, or a quote that are kind of the words that they live by. So it was a collective effort of empowerment and reclamation of self and personhood, and kind of a spiritual practice as well. You know, we kind of engaged in a grounding and a centering, and very much put that energy out there, the energy of love and connection and support to one another. And what I have found, support is really the #1 key for us being okay and trying to live any type of decent semblance of life on the other side, particularly when there really are no outlets for us to turn to get help otherwise. We understand each other because we've been there. We're not judging each other because we're all experiencing the same kind of things. We're not fearful when we speak to one another of the problems that we're having on the other side, because there's no fear that one of my fellow sisters is going to go run and tell the psychiatrist or the cops or the whoever and put us in some even worse situation all over again. So, I mean, you know, how we survive and how we are okay is we have just designed this network with one another to talk, to do artwork, to do creative writing, to do whatever we need to do to support one another to be okay. Because most of us, in theory, the people, places, and things you should be able to go to for help were the things that harmed us the most. And so we are now working in coalitions to build alternatives and alternative methods of healing, health, and wellness that does not involve more harm or punitive measures in the future.
Thank you for that. I'm just struck by how this is such a great note to end the series on, because I think your work really epitomizes the kind of underlying ethos of the series, which is for you all watching, those of you who are considering working with incarcerated people, getting into the field of correctional medicine. I think an important thing to keep in mind is to always take the lead of and to take the lead from and listen to incarcerated people and formerly incarcerated people themselves, because they are going to be the best source of information about their needs and what they need to heal, right? And also to consider, again, the other layers of healing that are not simply medical interventions, but these layers of spirituality, of community building, and expression that this work so epitomizes so well. So thank you, Anna. That's all we have. We'd like to open it up for any questions that you might have.
I actually have a question. So, and just because I don't know this, but who within the facility makes the decision to send someone to solitary confinement? And then going off of that, do physicians have the authority, power within the institution to fight against this if they don't think it's adequate for someone who's really suffering? So,
yeah. Kind of just about anybody who is employed at the prison could make a call for solitary confinement. You know, sometimes though, if the call was made by a lower ranking officer or a staff member from a different department, that decision could be overturned. But pretty much anybody employed there could make the call, you know, so it's kind of loose and again, arbitrary. You know, I mean, it can totally go based on one person's opinion or thought of whatever's going on in that moment. You know, very little needs to be said to send somebody to solitary. It's kind of like, well, we'll lock you up first and we'll figure out what the hell happened later, you know. And you could sit for a couple of days, you could sit for weeks, you could sit for months sometimes while they try to figure out, do you need to be there, don't you? Physicians do have a say in this, particularly people who are working in mental health. They can indeed advocate to put you there, but they can also advocate to have you come back out. So, you know, that actually in the early days of my incarceration was a situation with me. An officer had made the call to send me to solitary. I had been in solitary for a couple of days. It was actually the psychologist, not the psychiatrist at the time, who came to see me while I was there. And just deemed this is not a good idea. It's going to be counterproductive to keep her here. This is not okay. I'm making a verbal contract with her. If there's any kind of issue, she's to come to me, maybe let her stay off of work for a couple of days or whatever. Back in the day, they used to give us what they called the mental health days. That ended a long time ago, but people were becoming too stressed out or whatever. At one point in time, the psychologist or the psychiatrist could order that you had mental health days. Like they would give you kind of a vacation, if you will, where you didn't go to work or whatever for a few days, just had time to kind of rest and relax. They ended all those practices, kind of any semblance of decency of things that were going on as time went on were all taken away and disappeared. But at that particular time, it was absolutely a psychologist who went to bat for me and was like, this is absolutely the wrong answer. This is going to take a bad problem and make it a lot worse, which is exactly what happens, So in that case, I guess I was just lucky. It was the timing I was there. I had a great rapport with this particular doctor. He cared, he listened, and he was willing to fight. But as time went on, that's not the way it was going down anymore. So, but I do think as medical professionals, you do have a lot of power and a lot of pull. There is a lot that you can be doing to fight against this system and to work to change it. You are the professional when it comes to this, not the custodial staff who has not been trained in any of this. So what you have to say can and does matter. And you really can be that voice of advocacy to say, hey, this is not right, this is counterproductive, something else has to happen. But the more time went on, the less and less and less options people had to turn to, particularly for mental health services. I mean, it got to the point that if you weren't taking medication, you couldn't be seen by one of those doctors at all. You didn't get to see a counselor. You didn't get to see a psychologist. You didn't get to see any of those people. So, this was another way that they were strong arming people into taking drugs. The only way you get to have talk therapy is if you take dope. You don't take the drugs, you don't get to see anybody. So these things are problematic, and these are the things that need changing.
I would add to that too. Another place to advocate is with your professional organizations. So the American Medical Association, I think a few years back, did take a stance against solitary confinement in juvenile facilities, but has not done it across the board. But I think working with those kinds of professional organizations to have them take a hard line on the, a hard stance against these kinds of practices. So you have the backup. So if you do say fight the system, you have the backup of your professional organizations, some whistleblower protection. So that's another place to look to shift things, right? Everybody's hungry for dinner, probably.
I'm not mad at you. Well, I can just say this. If anybody in this room does decide that they have any questions that they'd like, to expound upon further, you are certainly welcome to email me, and I will get back to you as quickly as I can. I'm happy to be of assistance to any of you, however I can be, even if that's just sharing experience and knowledge or giving advice on different things. I'm totally happy to do that. So.
I actually have one more question. So did you feel comfortable confiding in your healthcare providers when you were incarcerated, or did you feel like it wasn't safe? Okay.
No, absolutely not. No, nope. Like I said, pretty much anytime I did confide in somebody, something even worse would happen. Like I said, I was really fortunate on that one particular instance that at that particular moment, we just so happened to have a doctor that gave a shit, but that was so rare. So, that was one incident out of a long line of situations that ended up okay. It didn't start that way though. I mean, their first response was, we're going to throw her in a cell naked alone and actually give her more medication, exacerbating the problem. So, anytime you would say anything to anybody, worse things would happen. I mean, there's a real reason why people don't want to tell you something is wrong, because what's going to look like when we do tell you something's wrong? How much worse is it actually going to get? And this is really the problem post incarceration now too. When you're not okay, who are you going to turn to? Because anybody you decide to go tell something's wrong, their first response is to lock you back up again. And this is where all the problems are really stemming from. So, it becomes this vicious cycle that a person cannot get out of. But then the problem is that when there's nowhere to turn because you do not feel safe, especially talking to the people in theory you should be able to talk to, this is exactly how people end up relapsing and attempting suicide and all of this other horrific crap, because they don't feel they're safe anywhere. There's no safety anywhere. There's no guarantee that someone is actually going to help you and not harm you further. So, I mean, this is why I think it's imperative, especially with medicine inside prison in any capacity, that we try to make that as separate from the carceral institution as humanly possible, because the less ties the medical providers have to the system itself, the more likely we are to have actual help instead of harm happening. When it is that intimately tied with the system itself, you are running under the regime of a system that is founded and sustained on violence, harm, and trauma. That is the actual purpose of this, and I think that's a problem too. People have been brainwashed to believe that, oh, this is rehabilitation. No, it isn't. It never was. It was never supposed to be about that. That's the nice language we put on it to make the world feel better about human cages, but that's not reality. The reality is for you to be sick and stay in the whole time. And if by chance you get out, to somehow or another pull you right back in again. You're not actually supposed to get well. You have to think about it. Corrections is the number 3 business in the United States. So in order for a business to be successful, what does it need, right? In this case, you got to have prisoners. If you don't have prisoners, your business is not successful. So when you have politics, medicine, law, all of these other things working in conjunction with one another to keep building this business, wellness is not at the core of this. Rehabilitation is not the core of this. It's sickness, it's disorder, and it's dysfunction. So we've got to recognize what it actually is first in order to be able to do something different.
We do have a question in the chat. And similarly, the question, actually, I'll read it first, is from Rick Bell. He said, what would you suggest for a health provider trying to develop rapport with an individual who was formerly imprisoned? I know you mentioned a lot about the physician that was there for you and kind of went to bat. What were, I guess, like some special qualities besides just being willing to listen that you can like vividly recall from him? So I guess a 2-part question there.
I think it was developing a level of trust too, knowing that this particular individual was absolutely not going to run to the next person in the chain of command with whatever it was I had been divulging. It was knowing that what I was saying there was pretty much going to stay there. And if it was going to have to leave him, there was going to be that baseline advocacy for me and what was in my best interest. It was not running to somebody else to sort of pass the buck off or whatever. It was saying, okay, here's the issue, but advocating for what he believed needed to be done that was actually going to work, rather than just handing me over to whoever and letting them make the decision of what was going to happen from there. So, I worked. It takes time. That's what I realized too. It takes somebody who genuinely cares enough to spend more than 5 minutes with you. who's really going to listen and pay attention and listen to what you're telling them is wrong and what you're telling them you think needs to happen to be okay. And it had been very few and far between in my experience with medical professionals that I found the people who were willing to do that. Number one, I'm the authority on my own body and mind. I know what the hell is going on here, so if a person is explaining to you what they think is wrong, and then specifically if they're giving you some ideas of what they think is going to help, you got to take that into consideration. Granted, you've studied medicine, you're the professional in medicine, but you're not the expert on me. You may be the expert on illness and disease and disorder, but you're not the expert on me. So it's coming to working communication and open communication and genuinely caring and being willing to just take the time to really get to know what's going on, the time to develop that level of rapport and trust. It isn't going to happen automatically, especially not in a carceral setting or with people who are formerly incarcerated. It's going to take time. You're going to have to earn people's trust, for one, because the automatic is going to come into this situation guarded, because I don't know who you are and I don't know what you're going to do to me and I don't know how much worse it's going to be. So, it's, you have to become a keen observer of people too. What's the body language saying? What are they saying emotionally? What are they saying on all levels? Just paying attention and being vigilant and taking that time. And, when applicable, if you need assistance and intervention elsewhere, trying to find that intervention with a person, place, or thing that, again, is not directly tied to the carceral system.
I would ask a follow-up to that, and that is, from your experience or from anybody's experience, which type of health professional do you think is best trained? So it's like social worker, nurse, I don't know.
It's such a tough call. Unfortunately, I haven't had the best experiences with any of them. So, it's hard. For me, it's always come back down to just an individual person, not so much their field or their title. It ended up being an individual person and where they were individually, just people who genuinely cared and were concerned. I'm gonna pat my colleague on the back here. Dr. Nelson is one of those people. She was coming in as an educator, but that's what I found in prison. Some of my deepest, strongest allies and advocates were actually people who were coming in for college programming. It wasn't the medical profession at all. It wasn't the social workers at all. It was people in complete, or, people who came in as volunteers with different spiritual groups and organizations. Sometimes those support systems and the best help came from people that were not at all in any of those fields that you would think would be the ones you should be going to for help. But again, it came down to the individual. I had plenty of other professors and teachers that I could not give that kind of accolade to. So, it was about individuals. I did have a psychologist that was amazing, but for the one good one, there was about 57 others that were horrible. I might have encountered one social worker who was great, one or two teachers who were great. It was the person. So I guess, the real question people need to ask themselves is, what kind of person do I want to be no matter what I'm doing in life? Who do I want to be and what do I want to reflect out to my fellow human being? Because at the end of the day, regardless of why somebody is in prison, they're still a human being. They're still like you. They still want the same things out of life you do. We've got to get away from the labels and the preconceived notion of what we're assuming people in prison to be, because a lot of times that's not an accurate story either. You know, the reality of how and why people ended up there is oftentimes extremely different than the story the public is being told. You know, and there's a reason for that too. That's a whole other conversation. But, you know, so it's, what kind of doctor do you want to be? And thinking about it, how would you want to be treated? How would you want your family members and your loved ones to be treated? How do you want that rapport to go down? And work on developing that rapport regardless of who the patient is in front of you. Because we know too, you know, we're people. You know when somebody's real. It may take a minute sometimes, just because we do have such extensive traumatic backgrounds, but we can see who the real people are too.
If we don't have any other questions, and feel free to interrupt me if you have one, I just want to say thank you to Dr. Nelson, Anastasia. I feel like I took so many notes, that this was incredibly impactful, this series, and this is exactly why we created this group, and this is exactly what we want the work we want to continue doing as we try to learn and grow throughout our studies in medical school, and beyond. So yeah, there were so many pearls to take away from this, and so many thought-provoking things. So I just want to thank you for taking the time to talk with us and share your stories. Yeah.
Thank you all for putting it together. Seriously, it's a testament to you all, of the kind of people you are, the kind of doctors you are becoming, to take an interest in this subject, this population. I mean, it's so often overlooked, and it's such a huge thing, as we've learned, right? So thank you all. I appreciate you all for doing this.
Yeah, and I just want to say, you know, regardless of which area of medicine you may be going into, if you have any plans to work with incarcerated or formerly incarcerated people, you have got to be trauma informed. You just have to. I mean, I don't care what field it is, you have to be trauma informed to work with this population. Because I'm hard pressed to think of any one of us who was there or who has been there that does not, that doesn't have this trauma issue now. So, you know, I mean, some of the trauma that happened to me was actual medical trauma too. I mean, not just psychiatrically, medically as well. So, you know, whatever you're going into, you've got to be trauma informed, and you have to administer care through that lens of being trauma informed.
Okay, well, we have recorded all of these sessions, so when they post, we will share them with you. And then we've also compiled a list of our next steps for medical students, things we want our students to look into and read about and watch and learn, and then our plans for the future as a student group. So we'll distribute all of that to all of you in the coming week, probably. And Kayla just dropped a document in the chat as well, from what we've compiled from the last sessions. So thanks everyone.
Thank you for having me.